My pleasure to introduce our speaker for today's Brain and Behavior Research Seminar Series, Dr. Holly Robson. Dr. Robson is currently a Principal Research Fellow at University College London's Language and Cognition Division, where she holds a Medical Research Council Clinician Scientist Fellowship. Dr. Robson began her career as a speech and language therapist, earning her Bachelor of Science with honors from University of Manchester, as well as her PhD in psychology from the same institution. And before joining UCL, she served as an associate professor in psychology and clinical language sciences at the University of Reading. Her current research explores the oscillatory dynamics underpinning continuous speech perception and Wernicke's aphasia, investigating whether these oscillations can be supported and manipulated to optimize speech perception and language comprehension in this patient group. Today, Dr. Robson will share recent advances in understanding comprehension deficits in Wernicke's aphasia and discuss how these insights combined with neurocomputational models can inform therapeutic approaches. So please join me in welcoming Dr. Robson.
Hi, everybody. Can you hear me?
Yep.
Yes. Yeah, brilliant. Okay, I know that internet's not always on our side, so if I cut out, just tell me where I cut out, and then we'll go back. But thank you so much for inviting me. It's really lovely to be with you. Tragically, it is actually after my bedtime in the UK, so if my word finding is abysmal, I'm going to blame it on that. So. Yeah, so yes, thank you for the intro. That's really lovely. I am going to talk about speech comprehension, which is, as we were chatting about, something I've looked into on and off since my PhD, really. And, you know, obviously the aim of that is to get us towards refining our interventions so they can be more efficient and effective. And so I put that as a title in the talk, and then my husband came in when I was putting the slides together, and he's an ex-academic, and he said, you know that if there's a question in the title of a talk, it's because the answer is no, which I didn't know that rule. Yes. Is that a rule? Yes. Okay, I'm going to go for the exception that proves the rule. Yeah, so that's the aim. So, okay. I want to fly the flag for comprehension, although I know that you guys are also the exceptions because you guys research this as well. But overall, comprehension impairments and aphasia are underdiagnosed and they are under-researched, even proportional, I think, to that underdiagnosis, so kind of doubly under-researched, and they only show limited responsiveness to our impairment-based therapies. So this is an area of unmet need and that we need to work on. So my work has focused on comprehension impairments of this Wernicke's type, so these are our individuals, as we know, these large lesions in the temporoparietal region, relatively preserved frontal areas. And I kind of feel the need to justify it because obviously this classification syndrome approach is quite old-fashioned, but I guess we sort of did it initially to reduce the heterogeneity that we were looking at and look at a kind of consistent cognitive network. And I think that has worked out for us quite well. But I don't mean to say that everything we see in the talk is only applicable to people with like a really pure, really classical Wernicke's type aphasia. I'm sure there are patterns that extend out, but I have to acknowledge that I don't know the extent of that generalization. Anyway, so this is an example. Here's our lesion overlap map. This is 33 individuals, and all of these people we diagnose behaviorally. So right, you guys have got Wernicke's, you can be in the study, and you see that it leads to this really remarkably tight lesion overlap map with sort of peak lesion somewhere underlying, usually posterior superior temporal sulcus in our experience. I'm going to try and play you a speech sample just so we're all on the same page. I don't know if this is going to work. It's a cookie theft, our lovely, not at all dated picture there. And I know that you guys work with lots of people with aphasia, so but the most sort of obvious feature of this group is their really fluent speech, which is pretty grammatically intact, but semantically empty, and also punctuated with those phonological issues that can become jargon in sort of severe cases. But in case anybody is less familiar, here's a speech sample. This is someone with like moderate Wernicke's type aphasia. And I have to apologise because I keep interrupting this poor man, and I'm also drinking a cup of tea, I think, at the same time. Give me a wave if you can hear this.
Describe the picture.
Yes,
Yep.
a little girl who's standing on the course,
Yeah.
on the stage, and falling off,
Yes.
trying to catch the cocker sharp
Mm-hmm.
on the little boy,
Yes.
peeking. Tip that over there. The girl is looking at it, giggling, laughing at the boy because, I think it's funny. And Mummy is served the socks and she's let in the sink. The ball is surging over the edge and flooding onto the floor.
Absolutely, yeah. Okay, so that's probably a profile that we all recognise quite well, yeah. The comprehension side, which is what I'm really interested in, is I think quite a lot harder to spot. And I know I've worked with these people for a long time now, and I still get tricked by people all the time in terms of underestimating the extent of their comprehension issues. So, and I think that's because, that's a really hidden disability, and it's either some people consciously mask it, but I think other people kind of unconsciously mask it as well. So in kind of general conversation, we get this like small talk effect where people appear to do really well in generalized, contextualized conversation. And then you ask somebody something specific and suddenly the conversation breaks down. And, at that point, people will often request a repetition. So they'll say, oh, sorry, what was that? Kind of like, they haven't heard you. They might start looking to a conversation partner to respond for them as well. We know that this group are supported by multimodal input, I'm sure, which is true of everybody with a comprehension issue. So gesture, writing, pictures, that kind of thing. And the other signal that sometimes I see, I don't know if you guys see this, sometimes people talk a lot. And that could be like an inhibition type of thing, but I think also some people just talk a lot to kind of control that conversation so that they don't lose track. So there are signals, but they're hard to spot in daily conversation. We talked a little bit before this about how we diagnose comprehension problems, and our behavioural assessment really still relies on some kind of pointing response in a picture matching task or a verification task. So is this a pineapple? You're supposed to say no, or you get a sentence or a word and you have to pick the corresponding picture. And often, we're looking at interesting syntactic profiles, and that can lead to us delivering quite strange sentences sometimes. These tasks are not that easy to create because we have to structure the errors, right, that people can make. So we have to kind of have insight into the experience they might have to give a reasonable set of distractors. And I think that can lead to some task insensitivity. The sort of other thing we could do to measure it is to use something like a patient-reported outcome measure, a PROM. And I don't know if you've, we've had a go at this with the Wernicke type group. And there isn't a relationship that I can see between people's reporting of their comprehension issues and then what we're measuring on behavioural assessment. And I don't know what the reason is for that. It could be some kind of insight issue, but I think that in quite a few individuals, people don't associate the experience they're having with a problem in understanding. And I think that might be to do with the nature of the issue. And then lastly, before we sort of talk about some of the data, we should acknowledge why we want to improve our interventions. And we've asked people, what's it like to have a comprehension issue? And people say, and it's really it really got to me, they say, we're really worried about stigmatization, that this issue particularly is going to be related to something, people are going to think it's about competence or intelligence. And so they were worried about that. And then all of these other issues, vulnerability, frustration, exclusion, all those kind of general aphasia things as well. And this participant says, said to us, she said, because not understanding someone, it's making me feel disabled by that. I don't like that. It makes me feel vulnerable, so I try to avoid it. I don't want to look silly, but I'm pretty good at it. If I need to mask something, I will. So big impacts. And this person has a really mild comprehension issue as well. Okay. So that's kind of the who and the why of why we want to intervene. Obviously, the what of intervention requires us to know the source of the breakdown. So what's impaired in the Wernicke's group. And of course, we've got this lesion, which is in a region of the brain which supports or contributes to functions throughout that, our comprehension hierarchy, including overlap with posterior aspects of the semantic system and also with the auditory phonological system as well. But I think, the historical perspective has been that this is an auditory processing condition. So because we've got significant overlap in the superior temporal region, in that auditory space, and because, was it Luria called it a sensory type aphasia, Wernicke said it's those images of words. The dominant opinion is that this is a perceptual problem with additional contributions from any kind of pick and mix of other things like semantic processing or lexical access or memory, phonological short-term memory. And that's it's interesting because that could be a total red herring. Do you have this term, red herring? Is that okay? Good, because I animated a herring. It's going to come. So yeah, because it could be this red herring because sort of given to us by this interplay of the vascular architecture, which is sort of, we've got these non-random distribution of lesion, right? We've got these consistent patterns, and then the syndrome approach, and those things together could be overemphasizing the role of this superior temporal lobe, and erroneously leading to that assumption that it's a perceptual problem. And and there is evidence to support that. For example, from word deafness, as we know, this selective perceptually based comprehension problem, that's what people tell us, usually bilateral lesions or maybe an interhemispheric disconnection. We've got that profile. We see in functional imaging, bilateral responses to speech. And so the interpretation is that surely the right hemisphere should be able to process speech at least sufficiently for us to comprehend. And that must be the case in some individuals, at least. I know we've all seen those cases with almost total MCA destruction in the left hemisphere and no apparent comprehension issues. So there must be some ability. The other issue we had historically, this is Sheila Bloomstein's beautiful study. So the issue here is that perceptual processing, as we measure it in neuropsychology, doesn't show selective impairments in Wernicke's aphasia. So this is the phoneme discrimination task. This is number of errors, and the Wernicke's in pink are making errors on the task, non-words and real words. But then also so are these other groups who don't have comprehension issues. So we didn't have selective problems. And so that was kind of the picture when I was doing my PhD a long time ago now. And the first thing we did back then was to try and develop measures that were sensitive, particularly to the auditory processing, potential auditory processing issue. So we tried to measure throughout this comprehension hierarchy in these Wernicke's cases. And when we did that, we saw that the lowest levels that we could measure of acoustic processing, like a pure tone discrimination task. So are these two frequencies different? People are intact at doing that. So that's fine. But then as soon as we add in any kind of modulation to the auditory signal, we start to see impairments. Sorry, this is really tiny, but this results on a ripple detection task. So people had to work out which stimulus had a sort of wobble in it, and we have elevated thresholds for everybody with Wernicke's aphasia. They need much more oomph to that signal to pick it up. We know that phonological discrimination is impaired. These are again, some sort of threshold data on a phonological discrimination task. Controls are at ceiling and the Wernicke's are above it. I don't know how to measure lexical access, so I always leave it out. And then also we see impairments on semantic tasks. This time it's an accuracy scale. So we've got reduced accuracy in visual semantic association in the green and synonym judgment in blue in comparison to controls. So that's all expected based on the lesion distribution.
Is it possible to interrupt for a quick second?
Yes.
Sorry, I'm
Yes,
Ed. Nice to meet you. Sorry, I'm joining remotely. I wanted to ask, so when you're classifying them here as Wernicke's, is this based on anatomy and symptoms? Like how do you classify them into that group?
Yeah, so in these studies, they're all classified behaviorally, but then we see this really consistent, basically Wernicke's aphasia lesions. So big lesions in the temporoparietal region with peak overlap somewhere between MTG and STG. Basically, yeah. And we use both a combination of sort of standardized assessment, but then also just our kind of opinions of what we think people look like as well. So it's not exactly just off the shelf. Yeah. So we see all those patterns, we expect all of those impairments. The question is, of course, what is the relationship between those measures and speech comprehension? And when we've done it before, our samples have been really small. So Lottie Messiard, who was a colleague of mine at Reading, she helped me to pull data from lots of our previous studies. And we ended up with a group of 36, which isn't huge, but I can't find a bigger one in the literature. We combined those auditory and phonological processing measures using sort of PCA. And we took one semantic measure, which isn't great, which is nonverbal semantic association, and we calculated an interaction term. And then we used those as predictors in different regression models predicting here Boston comprehension, and then just single word comprehension. And then we stick into the model covariates, so age, time post stroke onset, lesion volume, and importantly, that peripheral hearing. By the way, peripheral hearing is never, in my experience, associated with comprehension in the group. So when we do that, we see these are the coefficients in the model. We've got the significant relationship with the auditory processing and the comprehension, but we still are not able to measure a link with the semantics, and neither with the interaction. And I really thought that was going to be capturing something about kind of the whole system, but it wasn't. So this is the picture at the chronic stage. We keep on seeing it. This is the visualization of the link between the auditory processing and the language comprehension, and you can see it's a pretty strong relationship. So we can measure the relationship between auditory, phonological processing and comprehension. Is this a causal role? I mean, it's logical, right? But we also know that when we treat the auditory processing, we can improve it a bit, but it doesn't knock on to comprehension. So maybe we're just capturing something else about ventral stream function that's possible. And then we haven't been able to measure a relationship with semantics, and it's which could be because we haven't really been trying as hard. I have to acknowledge that we haven't got these same sensitive measures. But I think that maybe, it's illogical that it doesn't have any link, right? I think it could be that it's something to do with the nature of the semantic system, which seems to kind of shape shift a bit depending on the task requirements. And so it might be that using kind of traditional neuropsychology is just, we might not be able to see that link very clearly. Okay. The other thing we can do is look at recovery over time and try and look at the relationship between the comprehension and these underlying contributing factors, so the evolution of the system. Obviously, the group I've been looking at has a poor prognosis. They're still Wernicke's at the chronic stage. They have a poor outcome. But that seems to be the case across the board if you have a large lesion in your temporoparietal region. This is Stephen Wilson's beautiful study. This is a group of sort of neuroanatomically defined people with aphasia, not Wernicke's per se, but don't they look similar? And what we can see is in the first year after stroke, we've got this kind of incomplete recovery of word comprehension and really stalled recovery of sentence comprehension as well. So they're not doing great. We looked at recovery in this time period, so from essentially from sort of 3 months onwards, where we're actually missing data here. Yeah, so this is our longitudinal study. We had 12 patients in this study. It took me so long to do it. I don't regret it, but I sort of do. Anyway, we profiled people from 2.5 to 9 months. So at 2.5, 5, and 9 months after their stroke. This again is our Boston comprehension measure, and we see pretty much everybody improving on this measure, apart from this one outlier here, who's an outlier at 9 months. So keep an eye on this light yellow dot, which is the worst color to keep an eye on. That person doesn't change. So I assumed, because of those links in the chronic stage, that we were going to see this recovery in comprehension paralleled or maybe preceded by improvements in these auditory and phonological measures. And we see no change on these measures at all. So this time I've got up is better in these graphs. And yeah, we don't see any change on frequency modulation detection, those ripple tasks, on non-word discrimination or on word discrimination. Static over this time period when comprehension is recovering. The semantic measure, that same semantic measure as in the previous regressions, we see a small improvement in that over time. It's inconsistent though. And there, can you see my mouse? I don't know if you can. Right at the top of this 9-month graph, there's our light yellow dot. So he's actually performing the best on this measure. So we just didn't have the evidence to say that improvement in any of these underlying cognitive domains was driving the recovery in comprehension here. And then the other thing we did in this study was to say, okay, well, what is the relationship between our measures here and comprehension at our different time points? So if so these are whether we have significant correlations between these measures and comprehension, and we'd see nothing going on at 2.5 months. And then by 5 months, we see the relationship between auditory processing and comprehension emerging. And then lastly, what we did is to say, okay, if I take auditory processing at 2.5 months, is it related to comprehension at 9 months after I factor out initial onset severity? And there we found that to be the case. So those auditory measures and those phonological measures, they don't change, obviously. So at 2.5 months is related to the comprehension outcome at 9 months. So this is I quite like this. It's like, you know, at 2.5 months, it's like that early hot universe, right? Things are still really chaotic, and then they start stabilizing, and we see the patterns that you get in the chronic phase. We know these aren't improving, these areas, so it's like this reorganization is making better use of the signal that's left, or what's left, and therefore ultimately the comprehension outcome is constrained by auditory processing in the subacute phase. Yeah, it could be, of course, that we've got lots of movement before we're measuring, right? From which would make sense from onset to 2.5 months. but it's interesting, there's still a lot of plasticity in this system at this point in time. Okay, that's previous neuropsych. So this is the new data. So everything we've done in the past was really focused on measuring these sort of discrete, small, simple acoustic objects, auditory objects, and single words. And now we're trying to, as we said, move towards looking at continuous speech processing, because obviously that's much more perceptually challenging. I do think that there is a perceptual contribution to the Wernicke's type experience. So we're continuing to focus there. Right. This is just a slide from a previous talk saying it's really hard to process continuous speech. The signal is really complex, as we know, and you have to process it immediately. Otherwise, that now or never processing, something's going to come in and overwrite it. That's tricky. We've had this real fantastic development in understanding how the brain copes with continuous speech, and our measures to look at that. So we've got these two related concepts, cortical speech tracking and speech entrainment, slightly different. Speech tracking is this looking at time locking of neural activity to relevant speech features. So that can be any feature in speech. We see time locked. Entrainment refers to the phase and frequency alignment of oscillatory activity, and particularly to these fluctuations in the speech envelope. I've got a cartoon to show it. It's a bit dodgy. Here's the speech signal. Here's some ongoing neural activity. This is my line representing the envelope. And what we see, or what we think we see, is that this, when this information comes in, it induces a kind of phase resetting of the oscillatory activity so that it's lining up with the speech. And this is a kind of neural equivalent of us tuning in to somebody's voice or somebody's speech, I think. Mostly, we see auditory sources in this tracking, entrainment activity. And we see tracking at different timescales as well. So we see the brain pulling apart information at slow delta frequencies associated with these kind of prosodic fluctuations, and also tracking at theta frequencies, which is associated with syllabic information. So representing the acoustics, but we also get on top of this frontal sources as well, which are associated with tracking some kind of higher order information. I've been really purposefully vague there, because I'm not really, I think it's probably multifactorial. And we think that these frontal sources also might exert a kind of influence over the auditory sources to help them maintain alignment in the face of that quasi-rhythmical speech. And this gives us for intelligible speech than low or unintelligible speech. There is a question, is this actually a speech perception mechanism, or is it just a reflection of a sort of cortical representation of speech? These oscillatory models suggest that this might have a mechanistic role in helping us to extract information from speech by our neural populations are temporally aligned with when speech information is coming in. So we were at sort of highest points of sensitivity when that information arrives, kind of supporting that now or never processing. There's a massive proliferation of research in this area and relatively few examples of statistical links between speech tracking and comprehension. And it's, I don't think we should be critical of that. I think it's very hard to find if your system is working But there are a few examples where we can see a relationship between particularly theta envelope tracking and speech recognition kind of tasks. But the most, I think, and for me, the most convincing evidence that this plays some kind of mechanistic role comes from the TACS studies, which are able modulation of speech recognition depending on the alignment of stimulation and the speech envelope. So if it's lining up based on individual basically brain delays, you get this enhancement, or you can get an attenuation as well. Okay, I'm going to move on and actually show you some data. We've got the first studies showing we've got some atypical envelope tracking in aphasia, and it might be associated with overall severity. So this is Jill Crease's study that has come out this year. So the aphasia group here, reduced envelope tracking. But given all of those patterns that we've just talked about, it would be weird if everybody with aphasia was responding in exactly the same way to the speech envelope. So what we have started to do is to look at tracking in aphasia and ask if we're seeing any different relationships with different types of timescales of information, different frequencies. Is there a different relationship with speech intelligibility? Does it matter where your lesion is? So sort of starting to try and unpick perceptual and predictive and linguistic and paralinguistic contributions to tracking in aphasia. That's the plan. And then, of course, the important question, does this actually relate to comprehension? Everyone okay? Mm-hmm. Yeah, okay, great. Okay, so we have done an EEG study. We're still working on the interpretation. So feel free to comment on that element. So in this study, we have 3 groups, a control group with 15 in it, a temporal group with 15, and a frontal group with 14, which is so annoying. We try to, so in this case, we use predominantly a lesion definition for the groups. So we try to really have the groups to be anatomically distinct, and we've done a pretty good job of having limited overlap between them. But we still ended up with some really severe people in the temporal group. There's no difference in these other variables: age, hearing, lesion volume, time post onset, and they're all matched. Okay, this is our EEG paradigm, and I am feeling super smug about this paradigm. I love it. What we do is we play stories to our participants while we record their EEG, and the stories come from a learning to read book series in the UK, and they're targeted at about age 6. So they're semantically simple, they're syntactically simple, but they're quite fast paced. You've got to keep up with these, and they're about 6 minutes long when they were read. We chunk them into 4 different blocks, and then after each block, people get 4 picture verification trials. So was this a picture from the story or not? And it's really hard because we've given some really nasty distractors. You have to extract quite a lot of information to be able to do this accurately. And it's worked out really well because the controls aren't at ceiling and the patients aren't at floor. So we've got really nice spread. Everybody listens to stories in clear speech and also in unintelligible speech. So this is one channel, noise for coding, envelope is preserved, but you can't extract any information from it. And then we also, because we love making paradigms complex, we've also given the controls a low intelligible condition, because we know that listening effort influences influences tracking. So this low intelligible condition is 4 channel noise for coding, which is really, really hard. Tracking is analysed using the MTRF toolbox. So this is calculating the mappings between EEG and the speech envelope. And we have used both encoding and decoding models. So the difference there is with the encoding, we're trying to predict the EEG signal at every sensor. And with the decoding model, we're trying to predict the envelope data from all of the EEG sensors. And the actual value that comes out and what we put into our statistical models is the difference between how well we've predicted it with the true data versus how well we've predicted it with random permutations. Okay. So these are the behavioral results, if you can see them. It's a D prime analysis, so 0 is chance. And in all these graphs, you'll see the controls are in this sort of tealy green, the temples are in pink, and the frontals are in blue. So we've got no difference between the control and the frontal, with the clear speech and the temporal, as we expect, are struggling on the task, and the unintelligible really is unintelligible. And then here we swap out in this graph the clear speech condition in the controls for this low intelligible condition, and we've got super good matching at the group level here. So we've got behavioral matching, and that's all statistically looking good. Okay, so these are the tracking data. We're preferring to look at the decoding models, because these are the ones where we're taking all of the EEG data to try and predict the envelope data, and that sort of means that we don't have to cherry pick or select arbitrarily which sensors we put into the stats. So these are the decoding models. Reconstruction accuracy on the x-axis, speech condition on the y, delta on the left, theta on the right. Into the models, we also add age, hearing, and a kind of subjective measure of alertness, as well as covariates, but they don't have any influence. So what we have is a group effect. The controls are statistically different from the temporal group, but not from the frontal group in this case, but it still looks like the frontal are in the middle. We have an interaction between intelligibility, speech condition, and frequency. So intelligibility is only, in our case, influencing delta tracking. So something to do with having meaning in the speech that influences delta tracking. And we don't see any other interaction between group and condition and frequency. So all of the groups are kind of representing the speech in the same way, and they're responding to meaning in the same way. Now we can do that same thing. Now we're going to swap out the clear speech and the controls for the low intelligible speech. And when we do that, we lose the group effect in the decoding. So that's, that feels good, right? It feels like, oh, we're honing in on the source of the difference between these groups. But if you look at the unintelligible condition, it's still, there's group effects there as well. So I'm not really sure about this. I feel like I don't have full control over something, like attention or something's going on. But the picture here is mostly that when we behavior match, we lose the group effect, and that's driven by this delta. These are the encoding results. Delta tracking on the top, theta on the bottom, unintelligible in these three on the right. And it's not very exciting. You're seeing this intelligibility effect where the delta differs between the clear or the intelligible conditions and the unintelligible. And you're also seeing here this spatial restriction in the temporal group in the theta tracking. This is getting complicated, right? Gets worse. And there, yeah, this is modeling here of the exact same thing. It's just emphasizing that the group differences in the encoding is coming from sensors which look like they're around the temporal group lesion. So it's not very surprising. It's just logical. Did someone have a question? No, carry on. Okay. So these sort of group main effects it looks like it's this delta tracking, I think, that's capturing something related to meaning. But we see no relationship between delta tracking and our comprehension measures. So the pattern, it's a little bit confusing there. The theta tracking, which didn't look very different in the decoding models between the groups, is related to comprehension. So this is the syllable tracking rather than the sort of slower prosody tracking. And this is the case particularly, in fact, once I've removed any variance associated with any other variable that you can think of: age, hearing, alertness, lesion volume, etc. So I partial that out, and we see these relationships with theta tracking. So these are the controls showing the relationship between theta decoding and D prime for the clear speech at the top, the low intelligible at the bottom. And what you're going to notice is that this is a inverse correlation. So more tracking, stronger tracking, worse behavioral performance. The frontal show that pattern too, overall. This is for the D prime scores for the EEG paradigm. And then here's the temporal group showing a really super strong positive relationship. So we've got an interestingly qualitatively different relationship between theta tracking and comprehension in these groups. We also see these relationships generalized to offline neuropsych measures of comprehension. So that's the frontal lobe group again, showing inverse correlation with neuropsych measures and their theta tracking, and then again that positive relationship in the temporal group. And this is what it looks like again across the scalp. Time. And what we've done is to, because we've got these different directions, we've put everybody together using a quadratic fit, and we see this sort of significant quadratic relationship overall. And we're kind of we're not sure, we're interpreting it as a sort of modified engagement versus effort kind of a model. So the concept being that the temporal group are missing auditory regions and their auditory processing is poor. So the greater extent that they can align their neural activity with this syllable level information, the better that they're able to extract some kind of information that can make contact with meaning. Whereas in the control and the frontal group, their auditory regions are intact. So presumably their auditory processing is fairly okay. And we have measures to show that. But the task, as I said, is not actually that trivial. And what we know that there's this relationship between tracking and effort. So I think the more people are struggling with the task, the more effort they're putting into it, and then the stronger the tracking is. So we've got different types of effects coming up here. Okay, I'm going to try and summarize it, but we're still working on this. So delta tracking shows intelligibility effects. It's modulated when we do the behavior matching, but we see no relationship with task performance. So I think this is representing some acoustic information, but also some other information that is, I guess, non-semantic in nature, or it's not, whatever it is, it's not sufficient to achieve this task where you've really got to extract that semantic meaning. Whereas the theta tracking isn't affected by intelligibility. It's showing these really localized differences in the encoding maps, and it's showing this nonlinear relationship with comprehension. And I think that is consistent with this theta tracking being a very perceptually based process, and that is that we need in order to extract the information relevant for comprehension. The question is, what's that like, right, for people with aphasia? And so I said, I was at the UK Stroke Conference about a week and a bit ago, and I said, like, I don't know why I did this. I said, I reckon I've got an analogy for this. I think this is like the experience you have when you start speaking to somebody and you're sort of unprepared or unfamiliar with their accent. And there's like, do you ever have this? There can be this little tiny moment where you've not tuned in, and you know that they're speaking the same language as you, but you're not tuned into what they're saying. And then your brain very rapidly works it out and it gets into that kind of rhythm. And I wonder if for people with aphasia, it's like kind of coming in and out of that state a little bit. So I said this, and then after a talk, somebody came up to me and she said, "Oh, I had a stroke 17 years ago and I had global aphasia. And I didn't realize I had a comprehension problem until I'd been discharged from hospital, and I was sitting on the bus and there were people talking behind me and I couldn't work out what they were saying." And she said to me, and that was what the experience was like for me, just not being able to tune in and work out what it, and get into this rhythm of speech. Okay, I'm going to finish talking. Are we getting anywhere? Are we getting towards a better place for our interventions? I really think we are. I can see it kind of coming together. So we know the who. We know it's these severe, big temporoparietal lesions with superior temporal involvement. How much does that generalize to the global lesions is, I think, an important question. It really does look like there's some auditory processing impairment or something to do with that central to their experience, and the retention or restoration of that seems important for recovery. I would really like to know if we can work out what's going on with the semantics, and maybe these cortical tracking methods can give us some insights into that, in the same way that you guys are doing that with your eye tracking measures, or in those ecologically valid tasks. The when of the rehabilitation is really interesting. I don't think it's ever a bad time to intervene, but it really does look like we've got this dynamic system for quite a long time after the stroke. And can we give that system some better input as it's shifting and recovering? So either kind of before or at the early stages of that subacute period. But I don't know what's happening in the acute system, so I don't know if it's actually doing that itself anyway. And then lastly, how can we optimize the delivery of these interventions? And I'm really interested in whether we can use something like TACS to try and create a kind of optimal neural environment into where we're putting speech into. So can we support the alignment of that neural activity with the speech information to help people extract information? And if we can't do that, then maybe we can do it the other way around, like we tried in that paper, but it didn't work. So can we somehow modulate the speech signal so that it matches better to the kind of dynamic properties of people's residual auditory system? So lots of things to think about, but I think there's potential going forward. And that's it. And thank you so much for inviting me, and obviously to everybody who's contributed to the work.
No, we have time for questions.
We have time, yeah. People online, feel free to post your questions on the chat.
I have a question. I'm curious, when you were talking about sort of the accented speech phenomenon, like equating it to that, I'm curious if you've looked at all at alpha frequency and if you think maybe there's an attentional component sort of at play there.
Yeah, so we haven't yet. I think it's in the pipeline of the many different things we can do with these stimuli. You know, they're so rich. I think we were thinking of doing that yeah, to see if attention was sort of modulating the speech tracking in the other frequencies. We haven't thought about looking at the relationship itself with comprehension, so we could put that on the list.
Holly, can you go back to the slide about engagement and effort? And it's just so fascinating. Even I'm still trying to put it all together, but maybe yeah. Can you sort of unpack this a little bit? So you're saying that it's not about as Erin was asking, it's not about attention. It's about how much acoustic information just the people with temporal lobe lesions can process. Because it's not just about stroke either. Is that where you're going with that relationship?
Well, yeah. So I think so the interesting thing is that, you know, this theta tracking looks like it's not different, right, between all of the groups, but we can see then these different directions of effect in the different groups, and I think, you know, for sure, effort and attention is playing a role in the temporal group, but they're having to put in loads of effort and attention, probably, you know, almost across the board, because this is such a difficult task for them. Their ability to track, I think, is probably much more related to how the residual, you know, we're just measuring, right, in these decoding, especially in decoding, we're measuring from what's left. So how well is that residual system able to line up and follow these theta rhythms? In the other groups, you know, and you know what, it's complicated, isn't it? Because we're looking at tracking the speech envelope, but even if people are able to follow these amplitude modulations, it doesn't tell us that they're analyzing the actual content, you know, the spectrotemporal content of the speech, right, or the fine temporal structure. So it's probably correlated with that, but I think it's you know, in theory they're separate. So yeah, so in the temporal group, I think it's very much to do with auditory function and how well they can process or follow this continuous speech, whereas in the other groups, you know, their auditory function is better, and I think their pattern is probably driven by something, you know, either problems with the linguistic processing of the task, or the or something non-verbal, you know, how much they have to attend to be able to do this task. And those elements, if they're struggling with those elements, they put in a lot of effort to engaging with the task, and then that has this knock-on effect to how clearly we can see the cortical tracking, or how clearly we can measure it. Yeah, it's a work in progress, this interpretation.
Yeah, I mean, I'm not sure I fully even, I'm also trying to interpret it with you, but the other thing that strikes me here is the temporal versus frontal theta map. And so I guess what I'm also trying to interpret, and maybe this is not right, is that what brain resources these temporal patients are using is frontal, but it's not attentional either. Is that so? If you look at your
are we looking at this map here?
Yeah, but actually the one that looks like temporal versus frontal.
Oh, right. So this is
the one that looks like red, but because for all practical purposes, you're interpreting the frontal patients to be similar to controls, right? That's what that's sort of what you're doing. So here you're comparing the temporal patients with the frontal, and they seem to be engaging.
Yeah, I think this is a comparison of the correlation coefficient. So we're looking at sensors where we've got significantly different correlation coefficients here. So it's not that yeah, these areas are responding in different directions, I suppose.
It is not, or it is?
It is, yeah. I think
Yeah,
that's
yeah, okay, that's what I was thinking,
Yeah.
yeah, okay.
Can I ask a question?
Yeah, I mean, it's sort of interesting because it has implications for therapy, but I don't know yet what, so that's the part, sorry.
Yeah, yeah. I think it's these ones here, these sort of pink dots that are down the bottom, and you know, they're doing really poorly on the task. I think those are the ones that we'd like to say, right, can we get you to tune in a bit better? I don't know what it means else in the other groups. Because, you know, and in the frontal group, and even in the older adults, right, they're not they don't always comprehend well in those noisy environments, you know, in those everyday conditions. I don't know what it means for that. The frontal group actually are causing me problems because I really thought they were going to show a different relationship with the intelligibility to the other groups, and they haven't, and I'm just not sure I've quite set it up right to see that, because I thought maybe they would be less affected by intelligibility because, you know, they're not able to show kind of top-down predictive processing to the same extent as the controls or even the temporals. But yeah, I haven't seen that yet. Yeah. Ev, are you
can I
trying
ask
to
a
are you trying to say something?
Sorry, yeah, I have a question about, so this is a really great body of work. Thanks for sharing this. I wonder, so the idea here is to try to fix their auditory processing to try to get them better at comprehension. But I wonder if there are attempts that you have made or others have made to bypass this through reading. I mean, a lot of reading, of course, involves subvocalization and still requires speech level processing, but there's a handful of words, quite actually a substantial number, which can be recognized as whole words. And even in Wernicke's original writings, you can find kind of hints that for some of these kind of words that can be recognized without subvocal kind of letter by letter reading, you can recognize them and understand them just fine. And given that there's a lot of progress in NLP these days, you can presumably take like an auditory signal and quickly convert it into something like a message expressed in terms of these like short, frequent words, which may be just potentially a better route than trying to fix their, which just seems really hard to fix their auditory stuff. That's, I mean, kudos to you for trying, but I wonder if anybody's trying to do.
Well, we've not really tried yet. We've not really tried, but yeah, I think we can definitely do it better than what therapy looks like at the moment. But yes, you're right. That is a signature of this group. If they're very, very classical Wernicke's type condition, they usually show modality effects in their neuropsychology. So their reading comprehension is better than their word comprehension. But when it comes to sort of reading extended continuous passages, a novel, you know, everybody says no way, absolutely no way that we can do that. You know, that sort of
But maybe, but I just wonder, like, I mean, that's true. So yeah, they can't read novels. That's, you know, but to like for survival and everyday kind of face-to-face interaction where you get frequent auditory input, if you had like an app that quickly converted you, or at least like, it doesn't even have to be full sentences, right? Just give you like some words that could help you. Sometimes, you know, we infer a lot from context, right? So maybe just given access to the linguistic content through these words that they can recognize whole could be hugely helpful.
Yeah, absolutely. Yeah, and there are people who do that, who use speech to text. Yeah, and we did have a go. We've had a go at adapting longer passages of speech using generative AI to see if it can come up with something that retains the feeling of it, but reduces the linguistic complexity. And it's very entertaining. What it generates. Yeah.
Interesting.
Don't have anything online.
So where's this work going next, Holly? What's the next step here?
Yes, we're trying to sort out our priority list, Swati, really. So so with these data, the EEG data, we've used this MTRF toolbox, which is fabulous and probably picking up on both oscillatory and endogenous activity. So one thing we'd like to do is to try and separate out those two elements and look at much more at the sort of oscillatory contributions to this, because that's really that links much more strongly to these entrainment, these neurooscillation models that say, you know, the ability to follow and entrain at that level is related to mechanistically related to comprehension. So I'd like to have a look to see what's going on there. And then the idea would be to attempt some envelope TACS. The problem is I don't exactly know how to configure that yet, but TACS to try and you know, prime the what's left of the auditory system and align that that envelope TACS with some kind of task, probably a little bit more simple than this, probably a sentence level processing task, to see if we can support tracking and comprehension a little bit and have a go at that.
Would this paradigm be, I'm just thinking aloud, but would you be able to use like EEG as a biofeedback for these folks, but while you're amplifying speech and modulating the amount of noise, but then you're using these measures to sort of say you're close, you're getting there, you're not there yet, like something like that, sort of real-time neurofeedback?
Yeah. So Guanting, who is he's my technical postdoc. He is attempting that with people with cochlear implant. I think in theory it's possible, but it's obviously incredibly technologically challenging because of the timing elements and, you know, any kind of misstep. It was really hard to get the timing elements of this study right. So his is not online yet, as it were. So he's doing neurofeedback, but it's kind of offline neurofeedback. Yeah, that would be a dream, wouldn't it? That would be really fascinating.
I mean, that would actually prove your hypotheses completely right, in that what these folks need is some help to tune into what's important, and you sort of understand where in the brain to focus that on.
Yeah. Yes. Yeah. There's a lot of exciting possibilities with it, I think. And if you guys have any solutions to you know, then let me know. We can work on it together.
All right. I think we should let people go. It's past 5. Thank you so much. I know it's really late for you, but it was a treat to listen to this.